Welcome everybody again to our second installment of the Transforming ACEs or Transforming Schools Through ACEs Awareness webinar series. We're so glad that everybody has made time in their schedules today for this webinar. We know how busy and hectic things are right now with our new normal, and we promise to do our best to stay on schedule today. My name is Jeremy Braithwaite, and I represent EvaluAct. Our logo's in the bottom right-hand corner of the screen there. We are a collaborative partner to Healthcare Integrated Services on this project, the background of which we will be talking about in just a few moments. But just a few housekeeping items before we dive in today. For those of you that joined us last time, webinar 1 is currently, the recording is posted on the Healthcare Integrated Services website. And we will be sending that information out in terms of where to find that to everybody on this webinar later, probably early next week. We will also be sending out some handouts and materials that we reference in today's webinar via email to all of you as well. Finally, we will be sending out an evaluation survey that will be coming to everybody via email tomorrow. It's a quick survey in SurveyMonkey, and if everybody can take a little bit of time tomorrow to fill that out, we'd greatly appreciate it. So as folks may have seen in our advertisements, this webinar is really focused on transforming schools through ACEs awareness. And for those of you that are joining us for the first time today, let me just explain a little bit of the background about that. Healthcare Integrated Services, or HCIS as we'll refer to ourselves later, we have, HCIS and EvaluAct have been working together for a number of years in the areas of primary prevention, trauma-informed care, social determinants of health, and really centering that work where we believe it's most important and often overlooked among our youth and within our schools. And we've done this work, as we've done this work over the years, we've really realized the truly unique position that our schools and our healthcare providers working with students are to detect, treat, and mitigate the impacts of problems that, that our youth and our students are facing. And I think it goes without saying that in a global pandemic, there's no better time to start talking and having a dialogue about some of these issues. And so we've put together this webinar series as a vehicle to communicate some of the lessons learned and best practices that we've learned over the years with screening, identifying, and treating for adverse childhood experiences. And we're doing this in partnership with the ACEs Aware initiative, which is a statewide effort. We'll talk about that in a little more detail later, with the ultimate goal of building the capacity and building a community of care of providers to ensure a healthier future for our youth that are impacted by adverse childhood events and toxic trauma. So before we dive into our material today, I do want to just we would like to extend a note of appreciation to the Los Angeles County Office of Education, LACO. They've been extremely helpful in terms of helping us with outreach and getting the word about this webinar series out to as many folks as possible. And so they've really been the catalyst to bringing all of you to the table today. So we did just want to take a moment and acknowledge Dr. Deborah Eduardo, the Los Angeles County Superintendent, Dr. Victor Thompson, formerly of LACO, the former Director of Student Support Services, as well as Mr. Jose Gonzalez, the Director of Community Schools. And as I mentioned, today is the second of 3 webinars. So for those of you that joined last time, we talked about the issues surrounding screening and disclosure of adverse childhood events. And today we are picking that story up where we left off by focusing on, once we have identified adverse childhood experiences and toxic stress, what comes next in terms of coordinating care for those students. So this webinar, whereas the first webinar was focused on issues primarily surrounding intake, We pick up that story today by talking about the services planning and services delivery process for those students. At this time, I'd like to introduce our panel and get right into the meat and potatoes of our discussion. Again, we've put together a very illustrative panel of experts that are doing this work in schools right now. First, we have Dr. Ed Miller, the founder of Healthcare Integrated Services. Dr. Miller's academic background is in criminal justice and educational psychology, and her earlier career was centered primarily in correctional rehabilitation, and she's held various positions in California prisons and parole boards throughout the state. And it was through this work that she became astutely aware of the critical importance of screening, treatment, and mitigation of issues that stem in childhood that sort of inform the life course trajectory of the people that she was working with. And that most certainly includes the impact of adverse childhood experiences and toxic stress. And it was against that backdrop that Dr. Miller founded Healthcare Integrated Services to provide health, wellness, and life skills to some of our most underserved and under-resourced youth and communities. Justin Miller is the president and chief operating officer of Healthcare Integrated Services, responsible for all day-to-day operations, critical licensing, contracting compliance, audits with high-level governance and state officials, including credentialing, hospital privileges, and everything in between. In 2019, in recognition of his service to student and family health in the Los Angeles community, Justin received the very prestigious California Senator Stephen Bradford and Assemblywoman Autumn Burke Recognition Award. He is also a former McNair Scholar. Next, we have Dr. Bernard Hardy, who is the Chief Medical Officer and Medical Director of Healthcare Integrated Services. He has over 35 years experience as a general practitioner, as a family practitioner, 20 of those years spent in both inpatient and outpatient settings at Kaiser Permanente. He also has over 10 years experience working in school-based health settings. And finally, joining us from the San Diego County Department of Public Health is Mr. Dwayne Thompson, case investigator. Dwayne is a licensed vocational nurse and currently serves as a case investigator for San Diego Department of Public Health. He's an LVN and business administrator for Healthcare Integrated Services, as well as a certified behavioral health crisis nurse. He has experience working in inpatient hospitals as well as school-based settings. And he also coordinated the Vaccines for Children program, the Crisis program, and the Child Health and Disability Prevention program at Healthcare Integrated Services. So we have a very illustrious panel today. They come from very different interdisciplinary backgrounds. And I know that they have some very exciting content here for us today. And so at this point, I would like to turn it over to Justin Miller, who will be moderating the rest of today's discussion. Please, Justin.
Great. So let's just jump right into our learning objectives for today's webinar. And the first one is we will be increasing awareness about the ACEs Aware initiative. Secondly, we will be able to apply principles of trauma-informed care, including establishing trust, safety, and collaborative decision-making in developing treatment plans for ACEs-affected students. Thirdly, we will share lessons learned from our frontline experience in addressing trauma in youth. And lastly, we will be able to apply knowledge in discussion of our case study today and throughout the remainder of our webinar series. So in our first segment, we'd like to give a brief recap on what exactly is the ACEs Aware initiative.
ACEs is known as the Adverse Childhood Experiences. The leadership of the ACEs Aware Initiative is part of a statewide effort led by the Office of the California Surgeon General to cut adverse childhood experiences and toxic stress in half in one generation. The goal of the ACEs Aware is to seek help and provide Medi-Cal providers an understanding of the importance of screening of ACEs, training providers, and receiving a newly reimbursement platform. The pioneers of the ACEs, this first of its kind effort, is to enable early detection and mitigate the health impacts of ACEs. Again, it's led by Dr. Nadine Burke-Harris of the Surgeon General's Office and Dr. Karen Mark of the Healthcare Department of Healthcare Services. Sorry about that. What does ACEs Aware offer to Medi-Cal providers? Please visit www.acesaware.org for more information. You will learn about training, screening tools, and clinical protocols. And if a provider would like to receive Medi-Cal reimbursement, you must become ACEs Aware and certified. There is a billing option for the LEA providers. This option allows local education agencies, including school districts, county offices, universities, and college, to receive the federal share and maximum allowable rate for approved health-related services rendered to Medi-Cal eligible students. Getting certified. What does this mean? Medi-Cal providers will receive reimbursement for conducting ACEs screening for children, teen, and adult patients who have full scope Medi-Cal. This will be provided to you provided that the following conditions are met. Remember, you must become ACEs Aware and take the California training. There's no cost for this training. You may find it by visiting the ACEs Aware website. And of course, we all need CEUs. So those of you who have licenses that must be renewed, you will receive 2 credits applied to CEUs. You also must self-attest that the training has been completed. We discussed on the last webinar the Pediatric ACEs and Related Life Events Screener, developed by Dr. Dana Long out of San Francisco. This PEARLS form must be utilized when seeking reimbursement for the ACEs screening. When you visit the website, you will find the age-appropriate forms for children, teenagers, and adults. Although there are many ACEs screening tools and trauma tools that has been available for decades, and your institution may have their own protocols for dealing with ACEs screening. If you would like to be reimbursed for this new initiative, you must utilize this screening tool.
Okay, great. So at this time, we're going to turn to a small and quick activity that you may remember from our first webinar called Truth or Age, just where everyone's knowledge is surrounding adverse childhood experiences. We will be utilizing a poll question format during this part of the webinar, and you'll be seeing questions pop up on your screen. We'll be presenting a series of statements, and all we would like you to do is simply state whether you agree and think it's a truth to the statement, or that you think it's a myth, meaning that you do not agree with the statement or find some part of it to be false. We don't want people spending too much time thinking about their answers, so please just choose the first answer that comes to mind. So our first statement reads, School health providers can play an important role in coordinating access to immunizations for children. Do you believe this is a truth or myth? Please respond to the question presented on your screen. Great. Now, Dr. Hardy will present the results.
Well, let's find out what the answers are. Lack of access to immunization correlates directly with the development of ACEs. As a school health provider, we always try to coordinate access to immunizations with the educational health system. It is convenient for families to access vaccine shots on campus at a school-based health clinic, especially when there are barriers to transportation. So, this statement is a truth.
Great. Our next statement reads, it is the responsibility of parents and families, not the schools, to mitigate the impact of community or school violence. Do you believe that this is a truth or a myth? Please respond to the poll presented on your screen.
Like there's a few more votes still coming in, so we'll give people another couple seconds to put their answers in. And I believe we also have a few people that phoned in that won't be able to participate in the poll.
Okay, great. Now Dr. Hardy will present the results.
So let's find out. This is a truth or a myth. Violence in the community correlates very strongly with the development of ACEs. School health providers should coordinate with community leaders to ensure youth of the community are screened for childhood experiences or ACEs, especially after known acts of violence in the community. Thus, this statement is a myth.
Great. Our next statement reads, once a school health provider uncovers a chronic medical condition, such as anemia, it is imperative to immediately stop services and allow the student's primary care provider to take over. Do you believe that this statement is a truth or a myth? Please respond to the poll presented on your screen.
We have just a few more votes we're waiting on.
Great. Now Dr. Hardy will present the results.
So let's find out what the answer is. Lack of care for chronic medical conditions like anemia, asthma, and diabetes correlates very strongly with the development of ACEs. School health providers should always coordinate with a student's primary care physician to ensure an uncovered medical condition is receiving appropriate treatment as well as appropriate follow-up by the primary care physician. Thus, this statement is a myth.
Great. Our next statement says, if a school health provider uncovers physical abuse of any kind, it should immediately be documented, but it is the social worker's responsibility to follow up with the youth. Do you believe this is a truth or myth statement? Please respond to the poll on your screen. Okay, great. Now Dr. Hardy will present the results.
This one looks like it's 50-50. Let's find out what the answer is. School-based health providers are mandated reporters. Physical abuse correlates strongly with ACEs. Once uncovered, a school health provider should coordinate with school district administration, parents and guardians, as long as the parents or guardians are not the abusers. And they must correlate with the county social worker or to ensure that the physical abuse is being addressed at the source, not just documented and unreported. Thus, this statement is a myth.
Great. And our last truth or myth statement: parents have the right to stop their child's care and handle issues of violence in the home on their own. Do you believe that this statement is a truth or myth statement? Please respond to the poll presented on your screen. A few more votes are coming through. Okay, great. Now Dr. Hardy will present the results.
So here's the answer. Family violence within the home correlates very strongly with the development of adverse childhood experiences, or ACEs. If a school health provider uncovers family violence within the school-based facility, it is imperative, it is mandated to coordinate with the school's administration and county social services, as they often have their own protocols for meeting with parents to address reported violence. Thus, this statement is a myth.
Okay, great. Again, it is just great to see where everyone is in terms of their current views and surrounding the core issues of adverse childhood experiences. Thank you so much for participating. If you remember from our previous webinar, it's very complex and very gray, not just black and white. And what we know about adverse childhood experiences is rapidly evolving every day. So after this webinar series, we hope that each of you will be able to pass on some of what you're learning to your colleagues. So in this next segment, we would like to share just what we did and how we coordinated care after uncovering previous or ongoing trauma. So coordination of care began for youth with a clear operations plan established at the beginning between HCIS, school administration, and school staff. We coordinated with school staff training to begin beneficial ACEs screenings. We began triage with our lead registered nurse and team of healthcare professionals such as licensed vocational nurses and medical assistants. HCIS created an organized list based on patients with consents already on file for priority treatment unless evidence of distress or alarm. Once a patient was called back, the nurse reviewed the patient's assessment with the patient to foster a trusting, non-judgmental, and understanding environment to encourage disclosure. The nurse then determines the correct course of care for the patients, ranging from immediate to same-day appointments for high-intensity cases, or a scheduled follow-up appointment for medium to low-intensity cases. We would never turn away patients requesting same-day care without first being interviewed by an ACEs credentialed licensed healthcare professional. In certain cases, the triage nurse referred out after consulting with an HCIS physician for expedited emergency care or to an off-campus provider. Each patient encounter received a brief health and disposition assessment, had their vital signs performed, and was documented in electronic health records. So how does this all look from a clinical perspective?
During a student's intake process, it is important to consider three things: the patient's confidentiality, the consent for services, and a medical triage. What does that look like? Confidentiality, of course, is the utmost importance to each and every individual. No services can be rendered without consent, so that of course is very necessary. And the triage is definitely necessary to break down each case-by-case category into its intensities. The nurse will evaluate the client's physical or mental conditions by high intensity, medium intensity, or low intensity, based on the review of the client's provided information. The type of follow-up is dependent on the client's intensity. Immediate follow-ups for high intensity, such as thoughts of suicide or homicidal ideations, or follow-ups that can be scheduled for medium to low intensity, such as a hangnail, cough that will not go away, or other menial visits. The nurse will also act as a client advocate in order to coordinate required services or to resolve emergency problems in crisis situations. In those times, we will always consult with the doctor and proceed with the next steps.
Then the physician case review will be presented by Dr. Hardy.
Looks like Dr. Hardy's muted right now. Dr. Hardy, we just need to take you off mute.
Thank you. During the physician's case review, it's usually related to collaboration between the nurse assessment, especially with physician on high intensity cases. So this is where we collaborate almost always. On some of the medium cases, depending on the judgment of the screening nurse, we may collaborate on that. But the low intensity are usually handled by at the nurse level, but usually high intensity, medium are handled by both of us. In high intensity cases, the nurse will bring his or her findings to the physician about the case. And during the conversation, both will come to some agreed determination about referrals, about treatment, about assessment. The nurse and the physician will then meet with the student client to confirm the information presented by the nurse determination. And once we determine what the intensity is, then we decide how promptly we need to refer. Example, a student patient seeking a routine pregnancy test can go from being a low intensity case to a high intensity case if during the process, the nurse or the physician determined that this patient actually is a victim of sexual assault or rape. An example of how a high intensity case could become a low intensity case is that the physician or the nurse assessment is that this patient has the idea that language is a barrier and they're not going to be understood. So they check on the box that this is high intensity. But once we determine that the patient is informed that there is a translator available and is able to understand, then we can take them from being appropriately moved from a high to a low intensity. So always collaboration between the doctor and the nurse is important, but especially in the high intensity situations. Now, once we make an assessment, there are 4 types of treatment plans. If it's urgent, if it's an emergency, we have crisis intervention. If it's a medical emergency, we can call 911, the paramedics can come in and take the student right away. If it's a medical referral but not urgent, not emergent, then we can use the appropriate services following the school district guidelines. If there's a history of depression or mental illness, depending on the acuity, we may have to call in what we call a 5585, which is a psychiatric team to come and do an assessment on site. And of course, there's standard referrals depending upon the degree of intensity. The provider usually refers patients, clients, or family members to the appropriate community resources or to specialists. And that could include school district mental health, wellness centers, social services, and also county mental health as necessary to stabilize the student client.
Let's talk about collaborating with the school district. Collaborating with the school district as a health center is a critical part of the ACEs process. Let's dive into some of the reasons why it is so important to collaborate with school district officials. Dr. Hardy and Nurse Thompson spoke about the structured communication that is necessary for great coordinated health triage efforts. The coordination of the health team is very important, as Dr. Hardy mentioned, to determine if a student's case should be high intensity, which takes a lot of detailed oversight, medium intensity, or low intensity. If a case is low intensity, then the follow-up care is not so great. But understanding the case factors play a key role in coordinating a student's trauma case. For example, the clinical nurse may perform investigative duties such as determining if the student has an IEP, determining if the student has a previous child abuse report. This may involve contacting protective services, determining if the student has an off-site mental health therapist. All these factors are important in gaining the important information necessary for a good clinical assessment. Now let's talk about coordinating with school administrative staff. The health centers perform medical functions, but what about the school district staff during an emergency? If the school health staff determines, as Dr. Hardy spoke about, that they must perform an immediate psychiatric hold on the student, this may involve calling 911. Well, we do not want the school site surprised by an ambulance showing up at the gate and the school district doesn't have any notion that this is taking place. So great coordination of administrative support work must take place. The principal needs to know what's going on so they can institute their emergency protocols, such as being ready for the ambulance when the ambulance arrives at the school site. Most districts has a designated space where they may guide the ambulance. Districts have designated protocols during their emergencies where they institute particular staff to be on hand to work with police or fire paramedics who may arrive on the school site. Next, most importantly, the school institution has, various school districts has protocols of instituting, for example, a code red. An announcement may come across the loudspeaker stating that the school has a code red. This means that they're going to implement crowd control of students that are on the campus. This is necessary because while the ambulance is affecting transportation procedures for the sick student or removing the student from campus, the school district doesn't want other students crowding around the incident. So good coordination is very important, as you see, for many reasons. Lastly, incident reports. The health clinic must do great documentation to turn in incident reports, because if a crime has been committed or if the sheriffs or probation officers are involved, they need detailed facts of what happened, what led to the involvement of the police department, what are the circumstances that led up to having to call probation, the police department, or even the health department.
So in this next segment, we'd just like to share what we noted when coordinating care for adverse childhood experiences. Coordination of care can involve school administration. For some students, disclosed ACEs may require reporting to a school principal. You should always defer to the school administration for their implemented protocols when disclosed ACEs requires a network of healthcare providers. So what that means is school districts may have their own wellness centers or resources in place in order to promptly respond to uncovered trauma. What we did was we established protocols with the schools at the beginning before any services were administered to ensure proper coordination of care. Confidentiality should always be protected, but at times you must involve the parents. There may be occurrences where the youth may be at risk to harm or to themselves or to others. In these such cases, a patient might be put on a 55-85 hold, which is just a 72-hour hold for juveniles who might be at risk of harm to themselves or others. Properly communicating confidentiality rules with the patient will pave the way for other parties to exchange necessary information during the treatment process. Communicating this confidentiality rules at the beginning with the patient before treatment is administered will mean that the patient is fully understanding of the process and will not halt or hinder the necessary care that will be provided to them with other parties coming involved. Students may have an emergency which warrants coordinating care with local PET teams, social workers, campus police, or other emergency personnel in high-intensity cases. In these cases, we make sure to always check with the campus staff or administration to see if a student had an individual education program or IEP. So some other things we noted was at times guardians may object to a required 55-85 hold for emergencies. Again, that is just a 72-hour hold in case a child or patient has threatened harm to themselves or to others. In these cases, coordination with school principals and other administration staff is key towards facilitating a calm and comfortable environment to explain district or wellness center protocols. Once an emergency ACE has been uncovered, guardians may demand the situation be handled within the internal family structure. However, it is always important to remember that school staff, administration, and healthcare providers are all designated as mandatory reporters who typically have frequent contact with the children and have their best interests at heart. So in this next section, we'd just like to share a few issues that came about in our coordination of care and the lessons that we learned from them.
Let's speak about safe space. We have created a safe space where students now feel comfortable revealing years and years of concealed victimization and abuse. And what happens? The school is closed. The health center is closed because the health center works during the school district hours. Does a student ACEs or trauma stop because school is closed? No, it does not. What we found was that during holidays and other closure periods, students would call our 24-hour answering service to report feelings of anxiety or depression. Students' depression and other underlying issues does not stop during school closure. So the lessons that we learned was it is important to establish protocols with community social services, county mental health, community providers, including local hospitals and other clinics in the surrounding areas to coordinate follow-up care during weekends, summer breaks, and other school holidays.
Another issue that we found was an unexpected volume of uncovered ACEs that was revealed. Undetected ACEs and lack of follow-up care can lead to exacerbated trauma and underlying health conditions. And what we found that this was due to an unexpected increase in patients with uncovered ACEs who did not have a network of care or were unaware of the resources that were available to them. So the lessons we learned was to have tentative metrics on the amount of staff required to address and follow up with the ACEs patients to make sure that their services have been completed. Consider implementation of coordinated care with multidisciplinary health professionals to prevent disconnect and follow-up care. Make certain all disciplines involved with students' care plans are currently informed. So how we accomplished that was we would coordinate with local school-based resources on a monthly basis to ensure all agencies were informed with the needs of the youth that we all serve. Another issue we found was that it is crucial to establish protocols with the school districts with uncovered ACEs related to gang activity, weapons, and suicidal ideations. This is because we found that students would report these things due to underlying adverse childhood experiences in the past and were looking for support socially as well as treatment for their uncovered ACEs. So what we did was establish a protocol to work with school campus police, campus probation, and intervention officers, which included community gang prevention providers, to include in our intercession and clinical treatment planning. What this meant was this led to integration of community gang prevention providers within our coordination of care meetings towards ensuring youth received the help that they needed promptly. Okay, in this section, those who attended our previous webinar will remember that we conducted a small activity to show everyone how everything that we discussed looks in actual practice. Throughout our webinar series, we will be presenting an ongoing case study that demonstrates how HCIS has detected, addressed, and followed through with cases involving ACEs impacted youth. Additionally, the case study that we are presenting today and throughout the remainder of our webinar series is not based on any one particular patient's experiences. Instead, we've created a synthetic case study informed by our experiences over the past 20 years of care. However, even though this is a fictional case study, you should not think of this as an unrealistic scenario.
To review the case study from last webinar, the patient is a 16-year-old female who comes in for a pregnancy test. The patient completes the intake, minor consent, routine trauma questionnaire, and self-assessment. During these assessments, it is revealed that the traumas around various forms of violence and reported sexual assault are revealed. The student states that she does not feel safe at school and reported thoughts of suicide, isolation, and sadness within the past 6 months. The urinalysis screening is negative for STDs, but is positive for pregnancy. What we did during the last webinar, we asked the patient to consent to universal screening, and once the patient consented, she was universally screened through Pearl. So let's discuss what we will do during this webinar. What sort of actionable steps would your district take to, what sort of steps would your district take after the student revealed this trauma to you?
So for this section, we're going to go ahead and unmute yourselves. Feel free to join our panelists in this discussion. Also, we have a chat available if you are unable to voice yourselves at this time. We're going to go ahead and kick off the discussion with our panelists, but feel free at any time to shoot any thoughts that you have on your mind, any questions, or if you have any experiences in the past with revealed trauma, please share your story. So Mr. Thompson, in your experience, what sort of actionable steps would the district take after the student revealed trauma?
Well, with me, I would stay with the patient because suicide is a very real, very actionable thing for the patient. So I would stay with the patient, but I would get one of my coworkers, inform them of what is happening so that they can begin the process of letting the chain of command know what is going on. That's sending the doctor to me, notifying the principal and other administrative staff, as well as the director of the clinic.
Okay, great. Are there any other thoughts on this subject? Please feel free to join in. Also, we have a chat available.
If she's suicidal, we may need to address that also. We may need to get the PET team involved and make sure that she's taken care of from that standpoint. Also, as mandated reporters, we have to make out an actual report and make sure that is given to appropriate officials. Need to get social services involved, several things we need to do.
Another area of concern is making sure that the patient is comfortable. Of course, a lot of times and oftentimes things unravel quickly and unexpectedly. Like Dr. Hardy indicated, if a student comes in for a routine pregnancy test, which is not unusual, and then suddenly reveals all of this trauma that has been concealed and bottled up in them for years, of course, naturally, there are all kinds of emotions and thoughts going on that the patient needs to be comforted and made to feel a sense of safety, and that we're not going to leave them alone, that there's going to be follow-up. We will provide counseling and help them speak to their parents, because oftentimes the parents was not aware of victimization, including child victimization that had taken place when they were adolescents, 6, 7 to 10 years old. So it's very important to make sure that the student at this point is made to feel comfortable and to know that they are not alone and they will not be left alone.
Also, the student needs to feel safe from the perpetrator. The perpetrator may be another student on campus, which is a criminal act. So we have to get the authorities involved. And also, it may be someone at home who may have victimized her, in which case social services, and the police department may need to be involved. So this one has to be, safety is a major issue.
Absolutely. Thank you so much for chiming in with your thoughts. If there are no more participants in the chat or that would like to voice their opinion, I think we'll go ahead and move forward to the revealing of the case study.
Okay, so of course we would always remind the patient of her rights to confidentiality. Of course, we would ask that the patient completes a no harm contract. Someone will review the electronic health records for an IEP and an established counselor with the district mental health team. And then, of course, we will coordinate with the school administration, the campus police, and social services to complete a child abuse report. We will contact and coordinate with the local PET team for the 5585 hold, which again, as my fellow panelists have explained, is a 72-hour hold for the juvenile holds. And of course, we will coordinate with the school officials to contact the parent or guardian and make sure that they are well aware and involved in the process. I do want to encourage everyone to stay tuned and be involved in our next webinar, which will be the conclusion of this case study.
Absolutely. So if you want to see how all this comes together from case study part 1, part 2, and in our final webinar, we will reveal case study part 3 and show how everything would be resolved in this fictional case study. So at this time, I'm going to turn the reins back to Jeremy to wrap up today's webinar.
Okay, and I get a chance to redeem myself after that little snafu in the beginning. So again, thank you everybody again for joining us this afternoon. We do appreciate everybody taking time out of their schedules to be with us. We did want to mention that as we said, we will have an evaluation survey that is going out tomorrow to everybody that participated in today's webinar. This will be about a 5 to 10 minute survey. It's a SurveyMonkey link, so you just click on that. I think there's about 10 questions that you answer, but you know, it should take no longer than 10 minutes to complete that. So we would appreciate your feedback on that. We also wanted to remind folks that our next webinar is in 2 weeks, Thursday, March 11th. As Justin mentioned, that is the third and final webinar in our series focused on continuity of care. During that webinar, we're going to be discussing some really important things like ongoing monitoring and intervention, some best practices in telehealth, particularly important during a pandemic, and just as important, if not more important, issues of provider resilience and self-care. Thus far, everything that we have discussed has been very centered around the student, but of course, those that are entrusted with the care of our youth, we need to be thinking about ourselves as well in this equation. So we'll be discussing that too. We will be dropping the link in the chat right now. Yep, you'll see the registration link in the chat so that you can register for that. Please also feel free to forward that link onto anybody that you think would benefit from participating in that third and final webinar. Finally, if, as we had mentioned, if you have any, if you would like to find some more information about the ACEs Aware initiative, the website acesaware.org is listed right there. As I mentioned, we will be sending out an email with some materials and resources that that we discussed during today's webinar, including the ACEs Aware website. And of course, if you have any questions or if you want to learn more about healthcare integrated services, their website is healthcareintegratedservices.org. And we'll also provide everybody with the contact information for healthcare integrated services when we send out that email. So again, we do wish to thank everybody for making space for today's session. We do hope to see everybody back in a couple of weeks. So in the meantime, everybody take care of yourselves and remember to wear your mask. Have a nice day.